Welcome to the deep dive. Today we're really digging into something super common, acute lateral ankle sprains. Rolling your ankle. We're going straight to the latest evidence-based guidelines for primary care to see what's actually recommended now.
Yeah, and the mission here is to give you the most current thinking because things have definitely shifted. The focus now is much more on, well, functional recovery, getting people moving, rather than just, long periods of rest.
That sounds like a big change already. I mean, wasn't the first question always, is it a partial tear or a complete rupture, like grade 1, 2, 3?
That used to be the focus. But here's the key takeaway right up front.
Mm.
In that initial phase, distinguishing between partial and complete rupture, it doesn't really change the immediate treatment plan.
Oh, okay.
So because of that, the guidelines basically say simplify. Just classify it as either mild or moderate to severe. That's the crucial distinction for starting treatment.
And getting this right matters because, well, these injuries are everywhere, aren't they?
Oh, absolutely. It's incredibly common. Estimates are around, 10 per 1,000 patients per year in general practice alone.
Mm.
And you see a real peak in the sort of 12 to 18-year-old group. It's a huge issue, so an efficient approach is, essential.
Okay, makes sense. So first things first then. Before we even think mild or moderate, we need to be sure it's not actually a broken bone, right? A fracture.
Mm.
What's the go-to tool the guidelines recommend for that?
That's where the Ottawa Ankle Rules come in, the OAR. It's a really systematic, widely accepted method to decide if an X-ray is actually needed.
Right, the OAR avoids unnecessary X-ray.
Exactly. Saves time, cost, radiation.
Mm.
So the criteria are quite specific. First, the patient has to actually have pain in the malleolar zone, those bony bumps on your ankle.
Okay.
Then you need an X-ray if there's tenderness when you press along the back edge, the posterior 6 centimeters of either the inner or outer malleolus.
Got it. Tenderness on the bone itself.
Or, and this is a big one, if the patient just cannot bear weight, meaning they can't take 4 steps both right after the injury happened and when you examine them later.
That inability to walk, that's a major flag then. Does that same rule apply if you suspect a break maybe further down in the foot, the midfoot?
It does, yeah. For the midfoot, the rules point to an X-ray. If there's pain when you press on the base of the 5th metatarsal, that bone on the outside leading to the little toe, or if there's tenderness over the navicular bone, which is kind of on the inside arch area. And again, that inability to bear weight, to take those 4 steps, is also a trigger for an X-ray there too.
So why are these rules so trusted? What makes them reliable?
It's all about the sensitivity. The OAR has incredibly high sensitivity, something like 99.4%.
Wow.
Yeah. So what that really means is it's extremely unlikely to miss a fracture. If the OAR criteria are negative, you can be very confident there's no break,
Yeah.
and you can just proceed with treating it as a sprain.
Okay, so fractures ruled out using the OER. Now we classify. You said mild versus moderate to severe. How do we tell the difference? What are we looking for?
It really comes down to function and, well, the obvious signs. A mild sprain. A person can still bear weight reasonably well. There's some pain, maybe mild swelling, but not much, if any, sign of instability. They usually feel quite a bit better within, say, a week or two.
And moderate to severe?
That's quite different. You're looking at poor weight bearing, maybe none at all. There's significant pain when you touch the area, especially around that lateral malleolus, the outside ankle bone, and you'll see clear swelling, often quite a bit of bruising hematoma. And crucially, signs of ankle instability when you compare it to the good ankle. Recovery here takes much longer.
Right, weeks for work, potentially months for getting back to sports.
Exactly. And what's really quite concerning is the long-term picture. The initial pain might settle down fairly quickly, maybe in the first couple of weeks.
Yeah.
But the data shows that a really significant number of people, somewhere between a third and, well, over half, like 33% to 55%, still have problems 1 to 4 years later.
Seriously, that high?
Yeah. Residual issues like ongoing pain, the ankle keeps spraining again, or just that feeling of instability, like it's going to give way. Chronic ankle instability. It's a surprisingly persistent problem for many.
Wow, okay. That definitely changes how you think about just rolling your ankle. So let's get into treatment. The classic advice everyone knows is RICE, rest, ice, compression, elevation. How does that hold up against the latest evidence?
RCE, yes. Well, it's still very commonly advised. Something like 92% of GPs use it initially. But here's the kicker. The guidelines are pretty clear that there's actually very little solid evidence supporting the individual components.
Wait, so ice? compression, elevation?
The evidence that those things specifically reduce swelling long-term or significantly reduce pain or speed up recovery, it's surprisingly weak, almost non-existent according to the guidelines.
So all those bags of frozen peas, potentially not doing much beyond maybe temporary pain relief?
Possibly just that, temporary relief. And the real danger, the crucial caveat here, is letting the Rice-free principles, especially the rest part, get in the way of what we know is important.
Which is?
Early functional mobilization. Getting the ankle moving again, gently, guided by pain. Prolonged rest is actually seen as counterproductive now. Movement is key.
Okay, functional mobilization is the core. What about specific exercises? Should everyone be doing them?
Yes. Home exercises are recommended for all patients with acute ankle sprains, mild or moderate severe. They're low cost, easy to start right away. Simple things like moving the foot up and down, maybe some circles, gradually getting back to normal walking as pain allows. And there's some, albeit low quality, evidence they might reduce the risk of it happening again.
All right, so home exercises are a definite yes. What about sending patients for supervised physiotherapy? Is that always necessary?
This is another area where we need to be, well, cautious. The evidence comparing supervised physio to just doing the home exercises diligently, it's generally considered low quality.
And what does it show?
It suggests little to no significant difference in outcomes. Things like how quickly people recover, pain levels, or even the chances of re-injury.
So someone might be paying, 30, 40 euro per session multiple times for potentially no added benefit over doing the simple exercises at home.
That's the implication, yes. It means we shouldn't just automatically refer everyone. It becomes a discussion with the patient. They need to weigh the cost, the time commitment, against that limited evidence for superior results. Maybe for, say, elite athletes or people who keep re-injuring it, or those who you suspect won't actually do the home exercises, maybe then. But it's not the default first step. Home-based functional rehab is.
Okay, that's a really practical point. Let's talk about support tape versus braces. Are they basically the same thing in terms of portion?
Right, pretty much, yeah. The guidelines consider tape and bracing as equivalent options for providing that functional support while the ligaments heal. One isn't clearly better than the other for recovery outcomes.
And when should someone start using tape or a brace, and for how long?
Ideally, you wait for the initial, really acute swelling to go down a bit. So maybe start around day 5 to 7, and then continue for about 3 to 6 weeks, really just guided by their symptoms. The key is not to wear it continuously long-term. You want the ankle to regain its own strength and stability.
Are there practical differences, though, like cost or comfort?
Oh, definitely. A semi-rigid or a rigid brace usually offers more robust support than just an elastic bandage. It's reusable, which is good, but they can be expensive, maybe 20 to 70 euro, and often aren't covered by insurance. Tape, on the other hand, is cheaper per application, but you have to keep replacing it every few days. And some people get skin irritation from the adhesive. So pros and cons to both.
Right. Let's finish up with prevention, especially for people who are active in sports. What's the best advice to stop it happening again?
Well, the main recommendation is still those home exercises. Continuing them long-term potentially helps build strength and proprioception, maybe reducing recurrence risk.
Okay, keep doing the exercises. What about wearing a brace or taping preventatively? Like every time you play basketball or football, does that actually stop re-injury?
Now this is another finding that might surprise some people. When you look at the evidence specifically for wearing a brace or tape preventively during high-risk sports,
Yeah.
the data suggests there's actually no significant difference or very little difference in preventing another sprain compared to not wearing one.
Wow, really? Because you see athletes taping up religiously before every single game.
I know, it's common practice. But the evidence supporting it as a highly effective preventive measure just isn't that strong, according to these guidelines. It challenges that widely held belief. So it becomes an individual discussion again. Is the potential small benefit, or even just the psychological comfort, worth the hassle and potential cost, given the weak evidence?
That's fascinating. Okay, so wrapping this up, this deep dive really shifts the focus. The core takeaway for you, the listener, seems to be systematic up front. Use the Ottawa Ankle Rules to rule out fracture. Then focus heavily on function. Get moving early with home exercises. Don't just rest it. And be pragmatic. Tape and braces are equivalent temporary tools.
Exactly. And while that initial pathway is much clearer now, based on evidence, we absolutely have to remember that nagging statistic, that high rate of long-term problems, up to 55% still having issues years later. It tells us that even with good initial care, there's something about long-term recovery, especially preventing that chronic instability, that we still haven't quite cracked.
Absolutely. Which leads to that final thought for you to ponder. If we're doing the right things early on, mobilizing, doing exercises, using support appropriately, why are so many people, potentially over half, still ending up with chronic pain or instability years down the line? What's the missing link? Is it something subtle we're missing initially, like cartilage damage? Is it about proprioception not fully recovering? Or maybe even a psychological barrier to trusting the ankle again? Something to think about until our next deep dive.